Okay, so it's a pleasure today to invite have Mark Smyth here to give the postgraduate talk. So Mark, for the last 10 years or so, has been at the Peter Mac, where he heads up the tumour immunology program, and that is a really large and multifaceted program that is performing world-class studies on how cancers interact with the immune system at various levels, both the adaptive immune system, the innate immune system, and how that shapes the responses of the cancer cells. And Mark's lab in particular has been a real pioneer in developing models to investigate how the immune system tackles cancer, both in terms of mouse genetic models, but also antibody therapies and drug therapies and the like. And I'm sure you'll see some results of those sorts of investigations today. So Mark has won sort of a number of awards over the years. I think last year, you probably won the GSK prize. He's also lucky enough to be an NHMRC Australia Fellow. And just recently he's sort of developed his interest in cancer immunology into a new concept of immunoediting. I think we're going to hear some more about that today. It's a very interesting idea. So, what to do with it?
Thanks very much, Stephen. It's always a pleasure to come here and speak, and today I really tried to pitch this talk at a fairly general level. It won't be certainly too data rich. I'm going to discuss some results that we've got over the last 10 years, just to give you examples of the concept of immunoediting, but the idea is really to try and give you a broad overview of the field. So without further ado, the sort of outline of the talk is to look at what are the potential outcomes of the immune system tumour interactions, to discuss our current understanding of this concept of cancer immunoediting, to spend a little bit of time discussing whether immunoediting and pro-oncogenic inflammation are mutually exclusive or actually interrelated processes, and to try and relate some of these concepts to cancer immunotherapy. In the last part of my talk, I really just discuss where there's obviously a lot of approaches to cancer immunotherapy, but give you an idea about where the field's heading and I guess where the most promising results are at the moment. So I think we'd all agree that with the statement that immunity and cancer represent two cellular systems that can have profound effects on one another. And many currently view these effects as leading to two mutually exclusive outcomes. So specifically either that there's persistently activated components of innate immunity, or other words, chronic inflammation that facilitate cancer development, or that there's a balanced and integrated action of innate and adaptive immunity which can prevent cancer by a process that in the past has been called cancer immune surveillance. However, during the last decade, it's become clear that the situation is actually quite a lot more complicated than this, and the interactions between the immune system and the developing tumour can give rise to many outcomes that either provide host protection or favour tumour outgrowth. And for example, tumours developing in the immune-competent hosts are subjected to an immunoselection process where the most antigenic tumour cells are eliminated, leaving behind tumour cell variants that are either less well recognised by the host immune system or are more resistant to immune effector mechanisms. And the immune system may play an important developmental role in the evolution of tumours that are then fit to grow in an immunocompetent environment. As a result of this immune selection process, or as a consequence of other events, the developing cancer might co-opt the function of the immune system such that immunity now facilitates tumour growth. Several labs, including those of Yu, Richard Jove, Drew Pardol and Jennifer Grandis, to name a few, have shown that constitutive STAT3 signalling, for example, can often be observed in tumour cells, and this results in the release of soluble tumour-derived molecules that might either block dendritic cell maturation and tumour cell antigen presentation. They may compromise the development of protective T-cell immunity. They might promote the development of immunosuppressive regulatory T cells and myeloid-derived suppressor cells that produce immunosuppressive cytokines and metabolites, and some examples of those might be the cytokine IL-23 that we've done quite a bit of work on, and an IDO, for example. And in addition, they can induce pro-angiogenic cytokines such as VEGF that promote tumour cell growth. So the persistence of a non-rejectable, poorly antigenic entity, that is the tumour, leads to a reprogramming of the immune system function, which can protect the host to that which not only protects the tumour but which also actively supports its growth. So sometimes, for reasons we don't really fully understand, and this is a concept that we've been studying over the last 5 years, the polarisation between host protection and tumour promotion doesn't go to completion, and you get this metastable state of what we call equilibrium that develops where the tumour cells remain in an individual but their outgrowth is prevented by the cancer controlling actions of adaptive immunity. And I'll give you some examples of how we've shown that. In other words, the cancer is still present, but its growth is kept in check by immunological mechanisms that result in a state of functional tumour dormancy. Not everything that I've mentioned so far is about this sort of yin and yang of between the immune system and cancer, and it is really what I've talked about so far is really focused on the actions of the unmanipulated immune response, but there's also one needs to consider the effects of manipulating the immune response and manipulating immune system tumour interactions as a consequence of cancer immunotherapy. Some of these interactions might indeed recapitulate the natural process, but other effects might be quite novel to the therapy that's being used as an intervention, and they have the potential to sort of tip the scales away from tumour promotion towards host protection. So clearly the interaction between the immune system and tumours is complex. We still don't understand all the variables that determine whether the immune system will function to eliminate or support cancer, and we're not currently able to control this process with predictable certainty. So we've got host protective and tumour promotion effects under those umbrellas there. About 10 years ago, Robert Schreiber and I started to use the term cancer immunoediting to describe a process that gave rise to at least 4 of these 6 possible outcomes. So the classical immunosurveillance that Burnett and Thomas were the original architects of, equilibrium, which is this immune-mediated tumour dormancy, tumour sculpting, which is the sculpting of less immunogenic tumours in the face of the immune system, and this tumour-induced immunosuppression, which is being very actively studied now because there's a lot of lessons we're learning from that in terms of developing new therapies. So in terms of cancer immunoediting, Robert's group was really the first to coin this term, and did so in a first review in Nature Immunology in 2002, where Gavin Dunn was a very talented medical student in his lab. And we described the process where the immune system could protect the host against primary tumour development, that is cancer immunosurveillance, but on the other hand could facilitate tumour growth by sculpting the immunogenicity or attenuating the anti-tumour immune responses. And the evidence to support this really, which I'm not going to go through in detail today, but there's strong experimental data from a number of different labs that show that there's an increased carcinogen-induced and spontaneous tumour incidence in immunodeficient mice versus wild-type mice. There is also now quite compelling clinical data showing spontaneous immune responses to certain cancers, and tight correlations between the quality and quantity of immune infiltrates into cancers and patient survival. And the work most notable here has been in colorectal cancer, ovarian cancer and breast cancer, where there's been a number of groups describing prognostic factors or immune prognostic factors for outcome. So in terms of the primary data, the model that we've worked extensively on is this methylcalanthine-induced soft tissue sarcoma model, where you inject the animals with various doses of methylcalanthine, and then you can do that in wild type or knockout mice, and then assess tumour development in those animals over a long period of time. And the typical sort of data that one obtains is shown here. This is an experiment that was done actually in Bob's lab back in 2001 using wild-type mice compared to RAG2 knockout mice. This is on the 129 background. We've done very similar experiments in the black 6 background. And you can see the elevated incidence of tumours in the RAG2 knockout background compared to wild types. And often if the phenotype's very strong, one can also see a slightly earlier tumour development as well. So in this situation, the animal obviously lacks T cells, B cells, all T cells, including NK T cells and gamma delta cells, has an intact NK component. So we've used this model more extensively, obviously, to look at lots of knockouts, and I'm not really going to go through the data there, but essentially there seems to be a primary protective mechanism that involves both NK cells and NKT cells, the important immune cells in protecting from tumour development in this setting. The concept that immunity can shape or sculpt or edit tumour immunogenicity comes from the observation that tumours from wild-type mice are less immunogenic than tumours from immunodeficient mice. And again, using the same example that I just showed you before, if you take tumours that have grown out of either 129 wild-type animals or RAG2 knockout tumours, you can see if they're injected into RAG2 recipients that all these tumours are quite tumorigenic, so they grow very avidly in the knockout animals. But if you transfer them into wild-type mice, what you see is the tumours from the wild-type animals universally grow. They obviously grow at slightly different rates because they've got slightly different tumorigenicities. But if you transfer them into the ones that are derived from the RAG2 knockout into the wild-type mice, you see quite a heterogeneous pattern of response. So some tumours will grow very avidly in these animals, and other tumours grow and then are rejected. And this rejection is mediated by adaptive immunity. It involves both CD4 cells and CD8 cells. We've had a chance to do this kind of experiment in a lot of different knockout animals, so you can similarly take tumours that are derived from a trail knockout animal, transfer them into various immune deficient animals or wild type animals. The tumours that are derived from the trail knockout animals are more trail sensitive than those from the wild types, suggesting that there's been an immune selection for trail resistant variants. We've seen this also in the case of this sort of immunoediting going on in interferon gamma knockout mice, as well as type 1 interferon receptor knockout animals. So at the same time, work from other groups showed that tumours that form in wild-type mice can induce strong immunosuppressive responses through the induction or activation of regulatory T cells and myeloid-derived suppressor cells that can really inhibit protective immunity via a variety of mechanisms. And these involve molecules such as CTLA-4, IL-10, TGF-beta, arginase and IDO. They're perhaps some of the most well-characterised pathways. In addition, they can even employ certain immune component functions such as VEGF, STAT3 to promote tumour growth. So the developing tumour can sometimes impair or edit the effectiveness of the immune system to eliminate the cancer. And there's a lot of examples of where these molecules have been shown to be important. So this work overall led us to propose this sort of 3 E's of cancer immunoediting: elimination, equilibrium and escape. The types of stimuli that have been used to induce carcinogenesis have been quite various in terms of the mouse model systems that have been looked at. So I talked about carcinogens, but other models such as chronic inflammation, inherited genetic mutations, mouse models of cancer that we standardly know that represent human disease in terms of stage-wise progression, radiation, viral infection, these sorts of things have been looked at. These are sort of your classical oncogenic hits or loss of tumour suppressors. So in these scenarios you develop early transformation. You also need to really get loss of polarity or loss of ECM contact. That's another important step in terms of developing transformation, and I'm sure you've heard about that through other talks in this series. These transformed cells actually early on can express molecules that are detected by the immune system. So some of the best characterised pathways would be the ligands for the NKG2D molecule, which is an activation receptor on a variety of lymphocyte subsets. NK cells, gamma delta cells have it constitutively, but it can also be expressed on activated CD8 cells. These cells can recognise these ligands that are induced on just on stressed tissue. You don't find these ligands normally expressed on the normal tissue in the adult. And through that process of activation, the immune cells can interact with the tumour cells either by directly eliminating them through cytotoxic pathways or through secreting interferon gamma and having effects on the tumour microenvironment that are growth inhibitory. So in terms of elimination, a lot of these pathways have been determined using the sort of knockout strategies or using wild-type animals that are neutralised for these pathways. So experiments have been done in both types of experiments. There's also more recently been experiments done with even conditional knockouts of some of these pathways. And in these settings, the tumour incidence in these sorts of knockouts or wild types that are neutralised for these pathways is higher, and they have an earlier onset. This second phase, equilibrium, I'm going to talk about a little bit more, involves the immune-mediated tumour dormancy phase, and this is where there's an equilibrium between the immune system and the cancer, and this is essentially driven by the genetic instability of the tumour mass. There are, in fact, a lot of mutations that are being created in time in these lesions, and the immune system is interacting with this very dynamic population, and you can get this immune selection process going on. And finally, the last phase is escape, which is really the phase which has yielded the most information in terms of new therapeutics so far. So there are a variety of inhibitory mechanisms that the tumour can use to escape immunity, and a number of those represent some of the best targets that we've got at the moment for cancer immunotherapy. So just to talk a little bit about the elimination phase first. There are various molecules that have been looked at for their role in elimination. So there are cytokines that have been shown to be important, recognition receptors that are shown to be important in immune surveillance, and cytotoxic molecules. All of these have been studied in at least one or two different mouse models, sometimes more. Leukocytes have been shown to be important, so innate lymphocytes, as I mentioned in the MCA model, NK cells and NKT cells are important. In the, say, skin papilloma models, where you can apply DMBA and TPA and get papillomas and then squamous cell carcinoma, gamma delta cells are very important in surveillance in that setting. We're starting to get a better handle on the role of antigen-presenting cells. The tools for these are still really not as specific as we'd like. But certainly in the methylcalanthine system, Bob's group has shown in recent experiments the important role of the type 1 interferon sensitivity of the dendritic cell in terms of the response, as well as the role of cross-priming, at least in some of the model systems that he's looked at. But these need to be explored. The role of cross-priming needs to be explored in a lot more model systems. It's early days there. In addition, adaptive immunity has been looked at in terms of depleting various subsets of cells. And there's a list of groups here that have contributed a lot of this literature. In terms of immune escape, there are a lot of different mechanisms that have been accounted for in terms of escape. Classically, loss of tumour antigens. That might be specific peptide MHC complexes that are lost. That's actually been shown quite well in humans in terms of applications of cancer vaccines and peptide-based immunotherapies, where you can clearly select against a particular population of tumour cells and the antigen it carries. Loss of tumour MHC, you can get complete loss of MHC loci, as well as loss of NKG2D ligands. Loss of interferon gamma responsiveness is quite a common mechanism, so various defects in the interferon gamma pathway that can make tumours more tumorigenic. the inhibition of DC maturation and function, loss or inhibition of co-stimulation, and CTLA-4 is a really good example of that. Induction activation of Tregs. I haven't got time to show you, but we've done a lot of experiments now with conditionally knocking out Tregs in some of these spontaneous models, and Tregs have a very profound effect on tumour growth. So if you remove them, you can get very dramatic host immune responses where the tumours are rejected in a T-cell dependent manner. Myeloid suppressor cells have been characterised in a lot of different tumour model systems. We haven't done so much work with those ourselves. There's a lot of controversy about what really defines a myeloid suppressor cell. There's obviously the functional activity of the cells on T cells and their ability to proliferate and demonstrate antigen-specific function, but their markers seem to be quite heterogeneous in terms of what they carry. As well as there's immunosuppressive moieties that the tumours make that enable them to be immunosuppressive. So they're the sort of immunological mechanisms of tumour escape, but there's also the non-immunological. You're all familiar with the classical hallmarks of cancer. The nature of the tumour microenvironments, location, tumour growth rate, and various anti-apoptotic mechanisms. Location we've found to actually be quite important. In a number of the immunotherapies that we've administered, we've noticed that the results that one gets in orthotopic tumours compared to subcutaneously injected tumours can be quite different in terms of outcome and also mechanism of action. So I think that's an important point to note with your work. And then the stat-dependent mechanisms of tumour escape as well, which I've described. So until recently, a major hole in our hypothesis was the absence of experimental data that supported the existence of the equilibrium phase. Really, the least was known about this phase. Equilibrium was envisaged as a phase where the tumour cells are not destroyed in the elimination and persist and undergo editing. And it's really shaped by some of the early work by Jonathan and Wheelock, this tumour dormancy concept, where the in vivo proliferation of certain tumour cell lines could be prevented in mice that were pre-immunised against the same tumour cell line. They did this in various B-cell lymphoma models. It's quite old work. In addition, there's a variety of clinical observations, particularly published reports demonstrating the transmission of cancer from organ donor to organ recipient. And this is one such example of a case where the donor was apparently cured of primary melanoma 16 years before her death. Her kidneys were transplanted to two different recipients who obviously then also undertook immunosuppression for their transplant. And within about 18 months, both of these individuals developed advanced malignant melanoma in their kidneys, and the tumour was obviously tracked back genetically to the original donor. And there are a number of case studies like that. This one was published in the New England Journal of Medicine. So, does this really occur? Well, we set about, Rob Schreiber and I, a number of years ago to actually try and mimic this in a mouse model system, and we played on the observation that we'd had at the time that when we injected methylcalanthine into mice, particularly at low doses, we always saw a group of animals that carried a stable mass on their side. One could measure this mass for a good period of time, for 100 days or so, and the lesions would eventually dissipate and disappear. So there was always tumours that develop as primary tumours and grow out quite quickly, so the mass would be there and would continue to grow, but there was always a group of animals, a subgroup, where the masses disappeared. And we really wanted to investigate this, so we thought this was a bit odd that this was going on in some of the animals, so we decided to set up an experiment where we tried to intervene with those particular groups of animals. So Bob's group set up an experiment basically with the 129 strain. We were doing the studies here in Melbourne on the Black 6 strain. We induced tumours with methylcalanthine at a low dose. We then removed the tumour-bearing mice from the group, the ones that got primary tumours. We took the animals that were apparently either tumour-free, that is that they didn't have a mass that we could detect on their side, or they had these small stable masses, and we divided these into two groups at first. The first group we just gave a control antibody, and the second group we knocked out all the T cells and neutralised for interferon gamma. And so this shows you an example of this particular type of experiment, which we've now reproduced many times, This shows you the primary tumour formation, these lesions coming up quite early and growing quite rapidly in the hosts. In both in each of these groups, the groups are then separated, and one treats with either the control IG or the cocktail of antibodies. And the typical protocol that we used was to treat from 8 weeks, weekly from day 200 through to day 250. And what you can see is that here's the typical course of these lesions, which one can measure in the animals. They're in fact a little bit, we find them to be a little bit smaller in the black 6 strain compared to the 129. They're a bit larger, but they essentially dissipate over time. And by contrast, if you intervene with these T-cell depleting and interferon gamma neutralising antibodies, you see a very rapid outgrowth of these tumours at the local tumour site. I haven't got time to show you the data, but we've actually done this experiment over prolonged periods of time. So we've let this group go out for 300, 400 days and then done immune depletions, and we can still see, masses or certainly lesions in the host with malignant potential. So one can intervene even out at 300 or 400 days and still get tumours growing out in the host. We've looked at this in a lot of different backgrounds, and we're working our way through all kinds of genetic backgrounds at the moment. But the take-home message here is what we've found is that basically if you block adaptive immunity, or the main pathways that you think about in terms of adaptive immunity, CD4, CD8 cells, interferon gamma alone, or IL-12, in this case with an anti-IL-12 P40, you can see that there's an elevated number of lesions in these animals compared to the controls. By contrast, if we block some of the pathways which we've clearly shown to be important in primary tumour formation, like trail or NK cells, these manipulations have very little impact on outgrowth of tumours. So this equilibrium phase seems to be rather dependent on adaptive immunity as opposed to innate immunity. So in the primary setting, the innate immunity mechanisms seem to be important in preventing initial tumour development. But once tumours go into this equilibrium phase, it appears to be adaptive immunity that's important. Just some other observations from that study without boring you with all the details of that, but the mice developed small stable masses at the injection site, and these contain a mixture of activated immune cells and sarcoma cells. So we've got histologies where we've been able to show that. Sarcoma cells from these small stable masses were isolated, and they can form tumours when they're injected into RAG2 knockout mice, but they don't form tumours readily when they go into wild type mice. So they're still quite immunogenic, but are clearly transformed. The tumour cells held in equilibrium in vivo remain unedited, but they undergo editing when or if they spontaneously progress to the escape phase. So we've been able to show that with tumours that by contrast escape in wild type animals. So we believe editing occurs at this interface between equilibrium and escape. And in fact, editing may be occurring right through the entire process, we believe. The equilibrium seems to be the result of both anti-proliferative and cytotoxic actions of adaptive immunity on tumour cells. Our evidence for the anti-proliferative function is perhaps stronger. So if one looks at the aberrant fibroblasts in these masses and just focuses on those, they have a much slower proliferative rate by Ki-67 staining compared to primary sarcomas growing, and this is consistent with perhaps an effect of interferon gamma, which is important. But we really don't know whether there's a direct effect of T cells on these aberrant fibroblasts or whether it's somehow indirect. It could be through various elements of the stroma. There are a lot of macrophages in these lesions as well, and we're trying to determine at the moment how important they are. I should also say that this equilibrium phase has also been alluded to in a couple of other studies. So our study is really probably the best in terms of being able to visualise this equilibrium phase, but a study by Yossi Penninger using C-Sybil deficient mice or C-Sybil deficient T cells in a model of UV-induced skin tumours clearly showed an immune equilibrium in that particular setting. So he had animals that had been treated with UV irradiation left for a long period of time and then depleted of CD8 T cells, and these tumours grew out of the host. Another example would be the work of Jean-Pierre Abbastato, who has a model, a melanoma model of metastasis to the lung, where again these animals remain, the tumours remain dormant in these lungs for long periods of time, and he's shown by intervening and taking out CD8 T cells that these lung metastases can grow. In his setting, in fact, the immunity doesn't seem to really control the primary all that much, but controls the metastases. So there's a few examples where other people have shown a similar sort of phenomena in the mouse setting. So what about in humans? Well, obviously demonstrating immune equilibrium is something that we're thinking about a great deal, and would be what kind of context could one study that? In terms of immune surveillance, generally in terms of the first phase, I think there's it's pretty reasonable to question whether there's evidence in humans, and as I alluded to in the start of the talk, I think the best examples in terms of immune surveillance in humans are really these studies where immune markers are now used as prognostic indicators for outcome, and increasingly I think we're going to see this in terms of predicting patient outcome and stratifying patients into different groups for treatment. So my belief is that there are certain types of cancers where the immune system really probably plays no role, or the immune system's ignorant of those, and we've seen that in the mouse settings, in fact, that there's always a fraction of tumours that are generated de novo by, say, a carcinogen like MCA, that really it doesn't matter what kind of immune intervention therapy you give them, the most powerful ones we can manage, we don't have any impact on those lesions, and we're interested to know why that is. That's probably to do with the genetics of the tumours. But there's always a decent fraction of tumours where the immune system is impacting. And in this human setting, this study by Gallon and Friedman, which was published in Science a few years ago, they equated the number of effector memory T cells with outcome. And in fact, when one staged colorectal cancer based on all the other, the Duke's criteria, the previous criteria that were used, the immune pattern was far more significant in terms of its prognostic capability, in terms of where patients sat in terms of response. And this group actually has done probably the most beautiful studies. They've done these immune scoping really in colorectal cancer, but they've now also taken this into other cancers like lung cancer, ovarian cancer, with very similar types of results. And there's obviously a lot more mining that can be done there with this kind of analysis.
Paging, respond grade standard down, allied health reception.
Good timing.
Respond grade standard down, outside allied health reception.
So what are the questions that arise from the cancer immunoediting hypothesis? I guess one would be what determines whether a tissue or cancer is susceptible to cancer immune surveillance. That's not something we yet understand, but my gut feeling is that it's got to do with the genetic mutations that the lesion carries and how that obviously influences the microenvironment. But that's yet to really be proven. What mechanisms underlie the editing process? We really still don't have a good handle on that. Can we therapeutically manipulate the immune system to favour its host protective actions while reducing its tumour promoting actions? Certainly, that's something that I think a lot of groups are starting to do. A lot of pharma companies are interested in using what we learn from these types of model systems and applying that to the clinic. Can we reduce tumour-associated immunosuppression? I think undoubtedly we can, and there's a lot of different targets that one is looking at there. And can we therapeutically induce an equilibrium state in cancer patients, thereby convert cancer into a chronic controllable disease? We really need to know a lot more about this phase and whether in fact the rules that we learn about certain model systems obviously are going to apply in a clinical setting is quite a translational challenge, I think, but it's promising that one can actually observe this equilibrium state. It's a question of understanding what dictates that. Why do tumours escape that? Can we avoid that escape? Can we engineer the tumours into that kind of state where the host immune system is doing the work without further intervention? So now I'd like to sort of turn to the question about whether cancer immune surveillance, immunoediting and cancer promotion via chronic inflammation are mutually exclusive processes or two aspects of the same process. It's interesting, I think, that people who have studied lymphocyte biology have largely worked in this field, like myself, in immune surveillance, but all the way along in the last 15 years there's been a lot of people particularly interested in macrophages that have studied the ability of cell types like macrophages and mast cells to promote cellular transformation. And these two fields have been separated up until probably maybe 5 years ago, and we've started to share meetings together now where we're sort of starting to talk the same language. And it's encouraging, I guess, that groups like Lisa Cousins, who's traditionally worked in the inflammation side, is now doing a lot more immunology, and we're starting to understand that these sorts of processes are occurring in the same model systems. So this is the sort of question that we posed some time ago. If they're mutually exclusive, we shouldn't see them occurring together. But if they are two outcomes of the same process, then one might observe them occurring either concurrently or sequentially. We don't really have information about whether they're occurring concurrently or sequentially. We know a bit about the time frames, but what's interesting is that we've started to, I've showed you at the start of the talk a lot of experiments where one can knock out immune pathways and get more tumours, but there's also various manipulations that you can do that knocking out elements of the immune system that actually end up in tumour promotion. So one example that we started with was this MyD88 knockout, which is actually quite resistant to MCA tumour formation compared to wild types. We've done a number of experiments with other types of knockouts. So this shows you caspase-1 knockouts, IL-1 receptor knockouts, and NALP3 inflammasome knockout. And you can see in each of these scenarios, these animals are more resistant than the wild type to high doses of carcinogen. We have very similar results for, in fact, IL-23 knockouts are incredibly resistant to tumour formation. In some cases, obviously, some of these molecules, particularly MyD88, for example, might be expressed intrinsically in the tumour cell itself. But we're using, bone marrow chimera experiments, these sort of things, to actually distinguish the role of those molecules in the haemopoietic system in terms of prevention of tumour formation in the knockout scenario. So increasingly we're seeing evidence that the immune system can promote tumours, and we're seeing that similarly in the context of the same sort of model systems where we've seen immune surveillance. So clearly these processes are occurring in the same sort of time frame. So here's an example with the IL-23 knockout mice. You can see that at a dose of 100 micrograms or 400 micrograms, these are incredibly resistant to MCA tumour formation. So you can see here full tumour penetration here in the wild types, but much reduced in the P19 knockouts. And just as an example by comparison, the P40 knockouts or the P35, the IL-12 P35s, many more tumours. The IL-17 knockouts, really no phenotype in those. So MCA-induced tumorigenesis is an inflammation-induced process whose outcome is subsequently affected by cancer immune surveillance and immunoediting, and pro-oncogenic inflammation and immune surveillance are not mutually exclusive processes. This could also be said of other models like the DMBA-TPA skin model, where immune surveillance has clearly been demonstrated, but inflammation-induced tumorigenesis has also been shown. So just in the last part of the talk, I wanted to talk a little bit about immunotherapy. Now this area is way too big to cover in probably several hour lectures, and I just wanted to touch on a few aspects that I think leave some important messages for you. The first is the most promising type of therapy at the moment is to capitalise on these tumour-induced immune suppression mechanisms. And Jim Allison, many years ago, you would know him as a well-known immunologist who studied T-cell activation and control of T-cell activation co-stimulation. He's worked on the CTLA-4 molecule and others for many years. And it's this immune checkpoint blockade is the sort of term that's out there that's being used now in cancer immunotherapy and acting specifically at the synapse. So there are a lot of molecules that fit into this scheme where one's looking at, these are classically interactions that occur between T cells and dendritic cells, but this APC could just as easily be a tumour cell. Of course, them not being nearly as immunogenic as a dendritic cell. There are a number of pathways described here, all of which are being pretty actively targeted by various pharma groups. And the one of interest here, CTLA-4, interacts with CD86 and CD80, and it acts as a dampener of immune response. And essentially, CTLA-4 blockade can enhance tumour-specific immune responses. So it's there essentially to attenuate or terminate proliferation of T cells. And if one blockades this, you can get unrestrained proliferation of these cells. And Jim's group has really pioneered using CTLA-4 in combination with a number of different strategies. He's a firm believer that you can liberate antigen by a number of different pathways. We haven't really determined that these are that different. I mean, qualitatively, there are clearly differences in terms of how immunogenic some of these approaches are, and that's really the subject of another talk. For example, certain chemotherapies do create immunogenic cell death, and others are less effective at that. But the idea is that you can liberate antigen, and in the context of this blockade, you can mount stronger tumour-specific responses to antigen. From the mouse system, this is an example of some of the data that they generated with anti-CTLA-4 treatment. Interestingly, this agent isn't all that impressive in the mouse, and it sort of shows you that perhaps progressing these things into the human setting shouldn't always be based on the strength of observation in the mouse systems, but the results were encouraging enough in mouse systems to obviously take this forward. So this is an example where the single agent's very effective in this particular colon carcinoma model, but for the majority of tumour models, the impact of anti-CTLA-4 alone is actually fairly modest. And particularly when it's given to established tumours, it doesn't look especially effective in the mouse setting. But that said, ipilimumab was developed by Medarex and has been since taken on by Bristol Myers Squibb, who are a major player in this area. They created a fully human IgG1 monoclonal antibody to human CTLA-4. I've mentioned how that functions, and they've now looked at 6,000 patients have been treated to date. They've seen objective responses in late-stage melanoma, ovarian, lung and kidney cancer. There are adverse effects with this type of therapy. Obviously, blocking CTLA-4 interactions can potentially create autoimmunity, and we have seen that in the context of additional therapies in the mouse, but most notably in the humans. So these are the types of autoimmunities that one sees. There was a lot of concern about this initially, but with experience, I guess, clinicians now feel that these side effects are manageable, at least for the monotherapy. I think when it's combined with other things, that's going to be another issue. A phase 3 study in metastatic melanoma has been completed, and there are phase 2 studies ongoing in other kinds of cancers. And to just give you an example of the sort of results, you can. This doesn't come out very well, but essentially there's a very decent pleural effusion here and masses here which disappear very effectively 5 months after treatment with anti-CTLA-4. As another example here in patients, this is just the baseline. This is from Jed Walchok at the Sloan Kettering, and you can see in time 6 weeks and then 10 weeks you can start to see these lesions essentially resolving quite effectively in the patient. One of the interesting things, I think, is that this type of therapy has really changed the way that we oncologists are starting to think about monitoring disease. So there are a number of patients that receive this therapy in the first 6 to 10 weeks. In fact, the tumours look like they're progressing because there's a lot of inflammation in the site. These lesions actually get larger, so by the old RECIST criteria, these were progressing lesions and are deemed to be a failure. But in fact, after 16 weeks, you start to see, impressive responses in these patients, and by week 72, you've basically got complete resolution of disease. And there are a number of patients now. The complete response rate is about between 15 and 20% for the various lesions that have been looked at. But these are people that are basically walking tumour-free, which is essentially unheard of in malignant melanoma, apart from the occasional spontaneous regression. To give you an example again of pattern of response, here's the pre-treatment, here's the new lesions that appear to be appearing in these patients at 12 weeks, and then regression of these, and then still regressing. So there's a lot of heterogeneity in the response that one sees in the first weeks after treatment, but it's important to be looking longer term in terms of the outcome for these patients. So most recently there's been a large trial done in malignant melanoma looking at anti-CTLA-4 with or without a GP100 peptide, and the take-home message is that patients that are receiving the ipilimumab after 1 year and 2 year doing significantly better than those that are getting the control peptide alone. And this has now been approved for the treatment of advanced malignant melanoma in the US and is about to be released here in Australia. So there's essentially a 4-month survival improvement in malignant melanoma. So there are other checkpoints which are also being looked at. There isn't any strong clinical data yet published on PD-1 and PD-L1, but I can tell you that about 150 patients have been treated with this in the same disease setting in malignant melanoma, and the results there are absolutely spectacular, better than CTLA-4 and far fewer side effects. These other pathways are being looked at as well, LAG3, which interacts with MHC class 2, and we've had a strong interest in TIM3. So there are a number of inhibitory receptors which are making these T cells energic in the tumour microenvironment. So it's a question of working out what's going on in that particular tumour microenvironment, how the T cells behaving. But the data correlates quite well with the fact that there can often be large infiltrates of T cells in an environment but very little happening, and it's because of these kinds of pathways that the T cells are ineffective or not functional. So now in terms of therapy, I guess immunotherapy is really starting to get some momentum, and there's a potential to interface this with conventional therapies like chemotherapy and radiotherapy. So our group's spending a lot of time trying to work out what these sorts of therapies actually do to the immune system and how they might be combined. I haven't talked about agonists, so I talked about checkpoint inhibitors like CTLA-4 and PD-1, but there are a number of agonist pathways where one can drive a stronger response, stronger proliferation, stronger effector function, greater survival of T cells as well. So obviously combining these with conventional therapies, but also combining them with the checkpoint inhibitors will be very interesting in terms of how effective these approaches can be as combinations. Often single agents don't give you very much effect in mouse model systems, but you put the two together and you see a remarkably impressive result. So I think the quest will really be trying to define the patient microenvironment of the tumour, the genetics, obviously what the tumour microenvironment looks like, what pathways are immunosuppressive in that context, and applying the appropriate therapy to those patients. But these are essentially quite off-the-shelf therapies in terms of being able to deliver. Monoclonal antibodies have obviously made a big impact in cancer therapy already. So these ones now that are mobilising cell-mediated immunity are just another armamentarium. The other area of interest is adoptive immunotherapy. I think that deserves some mention. So this has been particularly useful in malignant melanoma. So the concept is to take tumour infiltrating cells out of the tumour or peripheral blood lymphocytes and generate tumour specific cells that way. Nick Restifo and Steve Rosenberg have really pioneered this idea. They started off with very non-specific sort of therapies, LAC therapies with IL-2. That's become very sophisticated now. We can transfer very small numbers of young T cells that are relatively undifferentiated, that are melanoma specific into patients. And they've got very spectacular results in a subfraction of patients. So you can see here pre-treatment and treatment of very large lesions, a massive lesion here on the back of one of these patients' heads completely resolved. So the success of this is really less clear in the fact that it's only been performed by a limited number of centres. It's a very high labour-intensive kind of approach. It's getting easier to administer, and I think we'll see more centres starting to do this kind of cellular therapy as it becomes more affordable and less labour-intensive. Smaller number of T cells can be transferred. It's been restricted pretty much to activity in melanoma and renal cell cancer so far. People are trying to genetically engineer T cells with appropriate receptors that will allow them to see other kinds of cancers. It's quite difficult to generate tumour-infiltrating lymphocytes from some types of cancers like breast cancer and some of the other types of cancers. Lung cancer is not so easy, so being able to genetically engineer these cells with appropriate specificities might increase the breadth of cancers that can be treated. So just to finish, I just thought I'd leave you with some reading. We've published a couple of reviews that are pretty comprehensive recently, one in Science and one in Annual Reviews of Immunology. I referred to this work if you wanted to see more about the experimental systems that we've used. And there's a very nice review here in Seminars in Oncology which talks about the T-cell checkpoint blockade pathways and what's interesting there therapeutically. So I'll just finish there. I just wanted to say that we obviously have a good research education program at Peter Mac. We have a lot of students over there. So just for those of you who are undertaking postgraduate training here in this environment, that if you're thinking about postdocs...
Attention please. Could Maria Alini please contact Environmental Services Office?
There's a lot of opportunities at the Peter Mac for further postgraduate training. So I'll finish there. I'm happy to take questions. Yeah.
I was really interested in the role of adaptive in the tumour propagation and CA mice. I was just wondering if you or anyone else have ever tried transplanting priming tumours into mice where their adaptive immunity is suppressed, wild-type mice.
Yeah, certainly. Are you talking about tumours that are derived out of wild-type animals and transferred into immunodeficient animals? Is that what you mean? Yeah, there's been a number of experiments where people have done transplants of tumours that have originated in various hosts into knockout animals versus wild-type animals and looked at the role of adaptive immunity in those. The transplant experiments are probably not the ideal way. They're a good way to try and demonstrate how immunogenic or tumorigenic a tumour is. But in terms of understanding the role of adaptive immune system in tumour development, the best experiment is to obviously treat wild-type animals with neutralising agents and then look at tumour development in that context, or to do it on a RAG background or some kind of knockout background. So there's a number of examples where in various mouse models of cancer where tumours have been compared in wild-type mice with various knockout mice or knockout for adaptive cells, for example. So that's been done, for example, in the skin papilloma model with gamma delta cells. If you take out gamma delta cells, you can get higher tumour incidence in those animals. If you take out alpha beta cells, interestingly, you get lower tumour incidence. So in that particular setting, it looks like adaptive cells might actually be promoting disease versus gamma delta cells inhibiting disease. With the transplant experiments, the difficulty there is for any tumour, one tumour that you take out, for example with the methylcalanthine system, every one of those tumours is different antigenically and somewhat genetically. I mean, there are some conserved genetic mutations like P53 and RAS, for example, are quite common in those types of tumours, but they carry a lot of different mutations. They're quite mutagenised as tumours go. And so if you just take one tumour out and transplant it into a wild type or a knockout, it'll tell you something but not much. You'd need to do that with a lot of different lesions to get an idea of the pattern of results. So we don't typically embark on those sort of experiments. They're so labour intensive in terms of looking at the role of immunity and protection of a particular model, we always just look at primary tumour formation.
Anything known about the role of OX53 positive cells or any other Treg in the equilibrium setting?
Yeah, we haven't published that at the moment, but we're currently preparing some studies. So we have used the Treg mouse, which is a transgenic animal where you can conditionally knock out Tregs with diphtheria toxin. And if you do deplete FOXP3 cells during that equilibrium phase, you can have an impact on tumour development. So those cells seem to be important in promoting tumour development. We've seen that in the primary tumour setting very strikingly though. So if you get rid of regulatory cells at the very time that you give the carcinogen in the first few weeks, you can actually, by doing that, I think, promote innate immunity, because regulatory cells control innate immunity quite significantly. So those animals are quite protected from tumour development if you get rid of regulatory cells. But as I mentioned, if you let the tumours establish, the primary tumours establish, so they're quite decent sized tumours, and then get rid of regulatory cells, it's very interesting. What you see is about a third of the tumours, nothing happens, they just keep growing. 30% or so of tumours reject and then they escape, so there's all kinds of escape mechanisms there. And then there's a group of tumours, about another 30%, that are just completely eliminated and don't come back, which is T cell, CD8 and CD4 dependent. So I think regulatory cells are really critical in that methylcalanthine system that we've looked at, but there's a number of other systems where regulatory cells have been depleted and shown to be important in terms of tumour promotion. Not so many people have done experiments on the spot, in terms of spontaneous tumour models at the moment, but I guess the tools for these knocking out regulatory cells specifically haven't been available that long.
Okay, so
Thanks very much.
Mark,